So next, we're going to bring up Chelsea Bowett. She is a med-ped doctor who is currently a cancer warrior, and she is going to talk to us about the overview of the continuum of providers who interact with patients prior to and up to a diagnosis. Please welcome Dr. Bowett.
That's the changer?
This is your advancer, yeah.
Okay, awesome, thank you.
And that's his point.
Okay. So today I'm going to address, so first of all, I'm Chelsea Bowett. I'm a primary care physician in Grand Rapids, Michigan. I have stage 4 colorectal cancer diagnosed about a year ago when my second child was about 9 weeks old. I had symptoms during pregnancy, which will kind of be reflected in what we chat about today. So today we're going to talk about who has the opportunity to be making this diagnosis. So as we know, early onset colorectal cancer, patients are symptomatic, tend to be symptomatic at diagnosis under the age of 50, and they tend to have poorer outcomes and more advanced stages at diagnosis. And as we just heard, this may be related to a delay in diagnosis. Up to 35% of early onset colorectal cancer, early onset, so patients under age 50, may be due to a known genetic mutations such as Lynch syndrome, FAP, any of these. But we also know other medical issues can be factors for early colorectal cancer. Things like cystic fibrosis require different screenings, which as a primary care physician, I had no idea until I started preparing this talk. So we really need to be paying attention to all of the predisposing factors. So we know most often patients are seeing their primary care doctors with their initial symptoms. Usually, early onset colorectal cancer patients, and we saw this earlier today, have numerous encounters with physicians prior to their diagnosis. And oftentimes, these visits are with their primary care physician, internal medicine, family medicine, and even pediatric and adolescent medicine. It's not uncommon for pediatricians now to be hanging on to their patients into their early 20s. So they really need to be as involved as our family doctors and our internists are in screening and discussion of symptoms and what is concerning, kind of education at an early age. Most all women in their 20s, 30s have an OBGYN. Not everyone has an internist, but most all have an OBGYN. So the gynecologists have a significant opportunity to screen and to talk about family history. Unfortunately, we see some people present initially in the emergency room to emergency physicians. It's uncommon, but definitely happens that the initial contact is with a gastroenterologist or a general surgeon or colorectal surgeon with symptoms of abdominal pain, et cetera. So we see the most common symptoms prior to diagnosis is universal throughout all age groups: rectal bleeding, anemia, change in bowel habits, either diarrhea, constipation, change in stool caliber, abdominal pain, unintentional weight loss. And if you combine if you combine rectal bleeding and one other symptom, has a positive predictive value of about 14%, whereas bleeding alone is far less specific. So if you're seeing people that have multiple complaints, that's something to be taken seriously and paid attention to and pursued. So it's the combination of symptoms that's really a red flag for us. So OBGYNs, we've been seeing an increased prevalence of colorectal cancer during pregnancy, which seems to be twofold. We know that the incidence of colorectal cancer is increasing in younger populations, and we also know that women are waiting until later ages to be having children. And so we're seeing those two paths are crossing, and we're seeing far more symptoms and far more diagnosis in the pregnant and perinatal time periods. Really, up to 1 in 13,000 pregnancies, which is actually pretty darn common. So anecdotally, a lot of people report a delay in diagnosis related to pregnancy, as symptoms are written off as normal pregnancy symptoms. Everybody's constipated during pregnancy. Everybody has hemorrhoids during pregnancy. You know, bleeding during pregnancy is no big deal. Whereas we're finding over and over, and patients have so many stories of, it wasn't hemorrhoids, I wasn't examined, I wasn't listened to, and you know, statistically, up to 85% of people in some populations have hemorrhoids during pregnancy. So we're talking about a very common symptom, and it's really difficult. It's challenging for our OBGYNs to parse out, you know, who we need to be pursuing and who we need to be, you know, talking about a colonoscopy during pregnancy. And we just can't do a colonoscopy on every pregnant patient who bleeds rectally, because that's impractical and not safe for the fetus. The OBGYNs do have a really great opportunity, though, to be getting a thorough gynecologic, oncologic family history, specifically to be identifying some of our Lynch syndrome patients as the presence of endometrial cancer, particularly young onset, is a huge red flag for Lynch syndrome. And our OBGYN colleagues have the opportunity to send those patients into an earlier screening program, or even into just genetic testing, because they pick up that gynecologic aspect of the family history. There was a study that came out of the UK looking at patients who were diagnosed emergently in their emergency department versus patients diagnosed non-emergently by their primary care physicians. The study showed that nearly all patients who were diagnosed in this study had symptoms up to 12 months in advance of diagnosis. And had been seen by their primary care physician or someone similar. The study showed that people who presented emergently were less likely to have been to their primary care physician with red flag symptoms, and we see that as kind of a gap where, had we been able to intercept them earlier, we could have had that earlier diagnosis. They found the relevant symptoms that were correlated with a colon cancer diagnosis: abdominal pain, constipation, diarrhea, weight loss, fatigue, with red flag symptoms obviously being anemia, rectal bleeding, and change in bowel habits. This study showed that people who presented emergently were less likely to be treated with a curative intent and were more likely to be diagnosed with more advanced stages, and overall had a decreased survival compared to patients who were diagnosed in the primary care setting. So these PCP visits present great opportunities for earlier diagnosis, for discussion of symptoms, for screening of symptoms, for asking pertinent review system questions during physicals, and trying to catch these patients before this is an emergent diagnosis. This study showed improved outcomes with patients who had an earlier non-emergent diagnosis, and that patients with typical red flag symptoms were typically diagnosed earlier than those that presented with more vague symptoms, who ended up being diagnosed in more advanced stages, and oftentimes more emergently with obstructions and pain. That's all I have for you today.